Well, hello, my name is Nilofer Azad, and I am a medical oncologist here at Johns Hopkins University at the Sidney Kimmel Comprehensive Cancer Center. I have been focused on taking care of patients with colorectal cancer for the last 15 years, and I'm very happy to be here today with Cancer Nursing Today as a roundtable to focus on colorectal cancer with two of my colleagues, Rachel Klein, who's a nurse practitioner who works at Johns Hopkins as well, and Fatemeh Youssefi, who is also here representing nursing that takes care of colorectal cancer. So, in our last few minutes, what I would love to do is to talk a little bit about some of the side effects that are a little bit more common in our drugs, and just talk about optimal management of a few of the side effects that are either unique or more particular to our drugs. And so I'm going to start with capecitabine and hand-foot skin reaction. Fatima, can you talk a little bit about how you help patients manage hand foot? How much do you see it for capecitabine patients, and then how do you help manage it?
So, again, as an infusion registered nurse, when these patients put a call through that comes to us versus directly to the providers, we take a call. Symptom management is a big roles of the oncology nurse, basically infusion nurse, if you will. So hand-foot syndrome, it's important to educate your patient on it. How do you start it? So if your patient's occupation, it is something that they're going to handle heat or having deal with the heat or extreme cold, those are all the reason for these patients to be more cautious and understand that maybe for the duration that they're on a capecitabine, beside the 7 days rest, they need to be careful. At one point, the sloughing of the hands. So good lotions and good creamings and good moistening of that skin is extremely important when they're taking capecitabine. Hand-foot syndrome, it's kind of got the grading that we talk about, that at what point is the one that the providers will say, you know what, we need to dose reduce, or we have to go down on a dose because it's such a, the grade 3 or so. So again, showing the pictures to the patients sometimes help to understand and what's the comfort of the patients with that symptoms that they're experiencing, to make sure that there is no actual skin breakdown that's taking place. And it's the sloughing is very contained to that surface of the hand and foot syndrome. So that's, again, going back to good educations. There are a great support group that's available that patients can talk and provide that feedback to their physicians.
Wonderful. Rachel, would you like to talk a little bit about oxaliplatin neuropathy? It's a little different than some of our other kinds of drugs that cause neuropathy. Maybe a little bit about, what we do to help handle it during treatment and then for patients who have neuropathy long term.
Sure. This is definitely, I think, a ubiquitous challenge in probably anyone who treats patients with chemotherapy, but the oxaliplatin-based nerve reactions can come in a couple different forms. One is immediate in the form of a cold sensitivity, and so we certainly educate patients about avoiding cold touch. So it could be avoiding ice, cold drinks, cold food, touching cold things, keeping gloves by the refrigerator. If it's winter, bringing a mask to wear or a scarf to cover their mouth, because often breathing in even cold air can cause a sensation in the throat that it's closing. Thankfully, it's not. Stepping on cold tile in the morning can be a shock, things like that, wearing slippers around the house. So educating about drinking warm fluids. You can also use that to decrease the jaw tightness that oxaliplatin causes. There's so many very unique things. I mean, people have told me about painful tears actually on oxaliplatin. So many different things. There's also a risk of hypersensitivity reaction with oxaliplatin. So the longer we give it to somebody, it's one of those drugs that later on in their therapy, they could receive 7 or 8 or 9 doses before they develop a hypersensitivity and can potentially be an anaphylactic reaction in the infusion area. So, you know, well-prepared and well-educated infusion nurses are critical to managing these reactions. And that's a key part of their job. And then also, with hypersensitivity, you know, evaluating the severity of the reaction, evaluating if we can potentially re-challenge the drug again with the support of pre-medications that may reduce the risk of reaction, or changing the length of the infusion, but potentially having a conversation with a patient about the risk of re-challenging. And then, of course, the long-term neuropathy with oxaliplatin can be very detrimental to someone's overall functioning. We really rely on their subjective descriptions. It's very difficult as a provider to ask someone to rate how severe something like this is that they may never have experienced before. And sometimes it can change pretty quickly. They're doing well for several months, and then overnight, I can't feel my feet, or I can't pick up a cup. I'm just dropping everything. I can't grip anything. And so we evaluate again the severity and see whether holding the drug for a period of time or reducing the dose may help alleviate these and allow us to continue to our goal. There are some medications that help with the pain sensation, the neuropathic pain, but really nothing can reverse the numbness once it is there. Besides potentially time, there's some evidence that acupuncture may be beneficial, warm circulation to the hands and feet, massage, moisturizing, for example, wearing socks and gloves. But unfortunately, once it's there, it can be permanent. So we want to try to do our best not to impose permanent damage on someone.
Yeah, I mean, luckily, oxaliplatin neuropathy for patients who get 6 or fewer cycles of oxaliplatin, so 6 cycles or 12 doses, it's 80% of that is reversible. In the metastatic setting, it's a little bit challenging because we don't have a break like that where we're like, okay, we're done, the way we do in adjuvant therapy. And so, and then the neuropathic pain medications, you know, the data for them is not great, right? So the pain scores can go down from a 6 to a 5 with you know, gabapentin, and you know, Cymbalta is a drug that's often used and similarly has a small incremental benefit for some patients. And so I think prevention and making sure you do dose reductions appropriately and meaningfully, and that you can advise patients, because it's very scary for a lot of patients to have their doses reduced. They are really worried that they're compromising the effectiveness.